It's a calm, quiet day in the ER. I'm just kidding, that doesn't exist. It's a busy day in the ER. And to complicate things, EMS brings a 22-year-old male coming in struggling to breathe. They throw him on the bed, you hook him up to the monitor. He's got a heart rate of 132, a pressure of 112/74, a respiratory rate of 17, and he's satting 89% on room air. You get some large bore IVs and throw a nasal cannula on him. You start at 4 liters a minute. He's like 90%. Max him out at 6. You're calling for RT. He's like hanging out at 93%. You take a look at this guy. He's leaning forward, using his accessory muscles. He's diaphoretic, anxious, speaking in short, choppy sentences, very much in respiratory distress. You go ahead and do a quick exam, trying to figure out what the heck is causing this hypoxia. He is sitting upright in this tripod position. He's got diffuse wheezes and a very long, forceful expiratory phase with accessory muscle use. And there's no air movement at the left greater than the right bases. You check the oropharynx, it's clear there's no swelling or edema, but he is tearing up with how much work of breathing he's doing. You check his skin, he's diaphoretic, but there's no rashes, no urticaria hives. Palpate his abdomen, it's soft and untender, and he is anxious and answering questions slowly and again in these short, choppy sentences. Okay, so the airway's intact but labor. Sats are now 92-93% on 6 liters, but no change in his work of breathing. So you tell RT to grab the nebulizer and you start running albuterol with ipratropium for this fellow. You go ahead and put him for continuous nebs and some IV methylprednisolone, which is solumedrol, 125, and a chest x-ray and a VBG. So his initial VBG shows a pH of 7.35. His PCO2 is 40. So you're thinking that he's retaining in the setting of an asthma exacerbation. His roommate rushes in and he's like, yeah, this guy has had asthma since childhood. He used his rescue inhaler like 6 times today, but it wasn't helping at all. And he was coughing all night after he went to an outdoor festival yesterday and said it was super dusty and thinks that it kind of triggered a little reaction. The dust and the allergen exposure probably set this off. But we also have to be thinking about infection, an allergic reaction, anaphylaxis, but at this point it's asthma until proven otherwise. We're gonna see how he responds to these therapies. Continue our workup. So RT gets him hooked up to this duoneb, and after about 15 minutes, his wheezing gets quieter and the nurse is like, he sounds so much better. And you check the monitor and his heart rate is 140 now, his respiratory rate is 30, he's satting 92% and still speaking in these very short, choppy phrases. Or worse, right? Quiet lungs means that the air is not moving. So you get a repeat VBG. It's showing an acidosis pH of 7.29. His PCO2 is 58, showing CO2 retention. So he's tiring out. He's not blowing off CO2 anymore, and we're heading towards impending respiratory failure. It's time to escalate. So your next steps are going to be magnesium sulfate, 2 grams IV. You want to do IM epinephrine, 0.3 milligrams, since he's not moving air, and then call RT for a BiPAP trial while preparing for intubation. On the BiPAP trial, and with these interventions, he starts kind of turning the corner. So you get some wheezes back. He's speaking full sentences, and so you're able to admit him for continued nebs and steroids. So this is a severe asthma exacerbation, what we call status asthmaticus, when it's life-threatening. The red flags are going to be speaking in short sentences, a silent chest, meaning no air movement, we're super tight, and a rising bicarb, meaning that they're fatiguing. They'll have lots of accessory muscle use, maybe some subcostal retractions or intercostal retractions along with tracheal tugging. Those are all the things that we look for in the peds population as well. There's a treatment algorithm to follow for all these patients and even a mnemonic biome, but out of order, it's going to be oxygen, beta